Hello, my name is Daryl Conway, and welcome to the virtual NATA Convention 2020. The title of my presentation is An Integrated Approach to the Multi-Systems Trauma Patient, Stop the Bleed and Beyond. So ask yourself, are you prepared for the ultimate emergency? Again, my name is Daryl Conway. My title is Senior Associate Athletic Director for Student Athlete Health and Welfare at the University of Michigan. My affiliations, I'm the owner of Conway Ventures. I'm a co-director for Sports Medicine Emergency Management and the assistant program director for Sports Medicine Concepts. I'm also an instructor with Stop the Bleed, a member of the Spine Injury and Sport Group, a member of the Zenith Scientific Advisory Committee, and a consultant for RG Medical Diagnostics. The views expressed in this presentation are mine and may not be the same as my employers, clients, and or colleagues. Please always use discretion and clinical reasoning when integrating the information, and always abide by your state license and local protocols and treatments or interventions as approved by your medical director. Our clinical question today: will the utilization of evidence-based triage and assessment techniques improve morbidity, mortality rates for traumatically and or critically injured individuals with major internal and or musculoskeletal injuries? Just a warning, some of the images may be graphic in this presentation. So why is this important? Many of us have to work Friday night football games. What you're hearing there are gunshots that rang out in the stands of this Friday night football game. Think about what would you do as an athletic trainer? Once you get your team to safety, are you going to go back out and respond? Are you going to go help with the triage? Are you going to go help with EMS in that situation? Think about this. We all ride buses. What happens when you have that bus accident? Are you prepared to respond? Are you prepared with your kit or a kit on top of the bus? So that you have your supplies readily available to respond to that situation. What about this situation? Looks like a normal Saturday afternoon football game. Could happen to any of us. Stands collapse, multiple casualties. Are you prepared to respond to that and manage those issues? We've all seen this picture before. This is a Boston Marathon. Okay, the people in white are the athletic trainers. Now, the Boston Marathon has tons of athletic trainers and are EMTs and paramedics and emergency room physicians and nurses, but they're generally about 400 to 500 yards away. The athletic trainers were the ones at the finish line manning that catastrophic incident as soon as it happened. Again, various different bus crashes. This is the Humboldt bus crash. This is Bluffton baseball team in Atlanta. This is our own basketball team here at the University of Michigan on their way to the Big Ten tournament. Plane skid off the runway. Okay, are you prepared to manage these injuries as probably the lone healthcare provider on scene? We all see the active shooter incidents, the multi-trauma active shooter incidents that have gone on, whether it be Vegas, whether it be Pulse nightclub, whether it be Sandy Hook, whether it be Virginia Tech. Again, we could all be there, and are we prepared to act? Okay, Joe Biden summed it up great. When tragedy strikes anywhere in the nation, the willingness and capability of everyday citizens to take action instead of being passive bystanders can mean the difference between life or death. Okay, understanding that we are the help until help arrives. So these are our learning objectives. We're going to talk a lot about the pre-hospital interdisciplinary healthcare team. We're going to talk a lot about the MARCH algorithm and different advantages, disadvantages, tourniquets, pressure dressings, wound packing, simple chest seals as critical interventions. What we're aiming to do is get you out of your comfort zone. Okay, we want you over here in the learning or growth zone with regards to how to manage a catastrophic incident or crisis manage. Okay, because we all understand that at some moment in our career, this may happen. Our life is going to change instantly, but understand that our mental fitness after the event will depend on our mental preparation before the event takes place. Understand we're not studying or practicing to pass the exam. We're studying and practicing for the day when we're the only thing between the athlete and the grave. Understand if it's predictable, it's manageable. If we can predict something's going to happen, we should be able to manage it. And understand there's no such thing as always and never. Every emergency situation is different. Every patient is different. Our individual circumstances must dictate our appropriate actions. Okay, so what do we know? We know as athletic trainers, emergency management and preparation is a component of who we are. We know we're both lucky and unlucky. We're lucky we don't deal with it that often, but we're also unlucky that we don't deal with it that often. We know the BOC has said that athletic trainers are expected to maintain a high level of preparation and proficiency in all aspects of immediate and emergency care. We know that calm is contagious, but so is panic. Okay, staying calm under pressure is a requirement for effective leadership. We know in times of stress, we are always going to fall to the level of our training, not rise to the level of our expectations. So where did we come from? Standard medical procedures have been developed for the treatment of patients in the traditional pre-hospital and hospital environments. But we may not work in those environments. We may not always be in that environment. And those procedures are not always applicable to what our work environment is. So we have to look at initial field care. First thing we need to ask ourselves is the scene safe? What resources do I have? Where should I be focusing our attention? Should I go back to old school ABCs, or should I concentrate more on CAB or our primary objectives? Circulation, airway, breathing. Circulation being, are they bleeding? Are they hemorrhaging? And do they have a pulse? And then get into a rapid trauma assessment that's going to allow us to assess the person, decide what immediate interventions need to be taken, and then act on that. So when we talk about MARCH, MARCH is an acronym that's used to identify and treat the major causes of preventable death in trauma. Okay, it's a methodical algorithm. Okay, it starts with, again, our primary objective of circulation or major hemorrhage. It then goes to airway, respiration, back to circulation or treating for shock, head and hypothermia, and everything else. And we're going to systematically go through all these points today. So we're going to start with massive hemorrhage. What is massive hemorrhage? What is that immediate life-threatening hemorrhage that's going to kill a patient? Okay, it's blood spurting out of the wound. It's blood that won't stop coming out of the wound. You arrive on scene, blood that's pooling onto the ground. Their clothing is soaked with blood. They've lost a part or all of her arm or leg. And then the big thing, bleeding in the victim who is now confused or unconscious. That's a sign of shock, and that's a sign that they've been massively bleeding from somewhere. So in trauma, you always hear about the golden hour, that we have an hour in trauma to get people to a trauma center to help them get help. As the war started after 9/11, they talked about the platinum 5 minutes. Okay, there's a 5-minute time frame for life-saving interventions with regards to penetrating trauma. Well, fast forward 14 years, and all the research that's going on from the war, they talk about that the platinum 5 minutes may be too long, especially in a tactical situation where you may not be able to evacuate the person, may not be able to get them to the trauma center right away. So we understand that a 3-minute time frame should be considered the upper limit of how long somebody can have uncontrolled blood loss. So we're going to look at the 4 Ds. Detect, direct pressure, and devices are going to be the main things that we look at. We will not talk that much about don't dilute, because in the athletic training environment, we aren't paramedics. We generally aren't managing to that extent. But the first 3 Ds, detect, direct pressure, and devices, are something that we're going to look at. So we start with detect. We're going to go through a systematic approach of detecting where they're bleeding from. This is called a blood sweep or a blood rake. We're using our hands, we're using our fingers to go in and out underneath of them to find out where they're bleeding from.
First, sweep the front and back to the neck. Then stop and look at your hands for traces of blood. From the neck, move down to sweep each arm, including the armpit, one at a time, stopping every few inches to look for signs of blood on your hands. When performing a blood sweep, use your fingertips. This will assist you in finding penetrating wounds as well as be effective in low-light conditions. Continue to sweep each leg, including the groin, again stopping every few inches to look for signs of bleeding.
So you see there how systematic, deliberate, using your hands, looking at your hands. It's important to pull your hands out every 6 inches or so to make sure you can tell where they're bleeding from, instead of running your hands down the entire length of the extremity. Okay, when we talk about direct pressure, use others to help. Okay, this is where bystanders can come in handy during this situation. Understand how much pressure you have to exert on somebody to stop a bleed. And then ask yourself, can you use alternative vascular pressure point techniques? Are those effective? The answer to that is yes. Okay, you can use some different martial arts techniques, whether or not you're using your knee or whether or not you're using your hand, to provide that downward pressure on a bleeder. Again, this can be helpful if you have multiple patients or they're bleeding from multiple locations. I can just kneel down, put my knee on one location, and work on the other while my knee is providing that downward pressure. Or you can, this is where a bystander comes in. You can use a bystander to provide that same downward pressure. And here you can see different martial arts techniques, the knee mounts, the elbow mounts, the hand mounts, where you can use to provide that direct pressure. Emergency trauma dressings, also known as Israeli bandages, okay, are great for direct pressure. Emergency trauma dressing is basically an ACE wrap with a maxi pad on it, okay? They can be used independently or they can be used in conjunction with our wound packing or hemostatic dressings. These are great to use in the armpits, in the groin, in the neck, all of those different junctional areas where a tourniquet's really not going to be effective and wound packing may or may not be effective, or you may or may not have time for that.
Deal with it from the outside package, and what you're presented with when you open it is a large area here, which has some gauze in it, as well as this cleat. So, as you can see on the instructions, it says other side towards wound. All you're going to do is grab it like that, and you're going to keep this facing down so that as you're unrolling it, it's not going to mess up on you at all. And something new that the Israeli dressing, the new Israeli dressings, is that if you drop it, it's not going to come open. And that's something that a lot of new dressings on the market, new pressure dressings have, is that if you drop it, it's not going to unroll on you everywhere. And that's what I like about the new Israelis. And you can tell it's new if it has this outer gray packaging. It's the new style Israeli. But once you open it up, you're going to put tension on it, and you're going to just take it around. You're going to go through that cleat, like so, and pull it like this. What that's going to do is you want that cleat where that tension is pulled to be directly over the wound, because what that's going to do is provide tension through this cleat right at the point. So let's say my cut was right here on my kneecap. I'm going to directly position this centered over my kneecap. So as soon as I pull this over, I'm going to feel that pressure right there on my kneecap. And I'll keep taking this around, and see that little piece of string breaks. It just continues to get pulled around. So, and the Israeli ends with this piece here. And all you're going to do is hook that in at the top and the bottom, and your Israeli dressing is complete. So that's a little how-to video.
So you can see, very easy to use. We've all used the ACE wrap before, where we've applied too much pressure to it and had to loosen up. Same concept. If you can't buy an Israeli dressing or emergency trauma dressing, you can just use your ACE wrap. But we're just making sure that we're pulling it very tightly. You can see the benefit of this is it has that cleat that provides an extra layer of direct pressure right over the wound. So we've talked about detecting and doing our blood sweetened blood rake. We've talked a little bit about direct pressure, whether or not it be just with your hand, whether or not it be from martial arts technique, or whether or not you're using emergency trauma dressing or Israeli dressing. Now we're going to talk a little bit about devices that we can use to stop the bleeding. So we're going to start with tourniquets. Okay, tons of research out there. Patients who had pre-hospital tourniquets applied prior to the onset of shock had a 96% survival rate. So what this is saying is, you don't get the tourniquet on before shock is set in, that person has a 4% chance to live. What are some of the complications of tourniquets? The biggest one is they hurt. Okay, when you apply a tourniquet correctly, the person's going to be in pain. It's going to hurt a lot. You need to explain this to your patient. Okay, pain does not mean that it's been applied incorrectly. It does not mean that you should peek, that you should take it off. Again, your goal in applying a tourniquet is to stop the bleed. Okay, but explain to your patient that it's going to hurt. Several different types of tourniquets out there. The CAT tourniquet, combat application tourniquet, is the most popular. The soft T and soft T wide tourniquets are also popular tourniquets that's used in the military and tactical and police. The stretch, wrap, and tuck, also known as a SWAT tourniquet. You can see a picture of it here. The SWAT tourniquet is orange TheraBand. Okay, so again, when we get into our improvised tourniquets, what can I use? I can use this TheraBand that's in my kit. I can use a blood pressure cuff. I can use a triangle bandage, a bandana, a belt, clothing, anything that I have if I don't have commercial tourniquets. Be aware of counterfeits. You're ordering from Amazon, you're buying various different things in catalogs. Be aware of counterfeit or fake CAT tourniquets. They do have a tendency to break. A CAT tourniquet is made by North American Rescue, costs anywhere between $18 to $22. So be aware when you're on Amazon, you're getting 3 for $9. So with a tourniquet, set yourself up for success. Tourniquets come wrapped in plastic. You can see this windlass strap is usually all the way over on both of these clips. What you want to do is move this windlass strap to one side. Okay, that way when you need it, you aren't fumbling around with a little white piece of Velcro trying to get it off in order to apply the tourniquet. Where are we going to place tourniquets? Okay, if we're under fire, if we're in a environment that's not safe, if it's in a low light situation where we can't visualize exactly where they're bleeding from, we want to present the tourniquet or place the tourniquet high and tight. So as far up in the axilla, as far up in the groin as possible. Okay, if we're in a secure setting, if we're in a setting where we can visualize exactly where the bleeding's coming from, if we're in a setting where we can cut away clothing and see the exact place of the wound, okay, at that point we're going to place a tourniquet about 2 to 3 inches above the bleeding site. Okay, again, making sure that we expose the extremity, making sure that we don't present a tourniquet or place a tourniquet over a joint, over an impaled object, or directly over a compound or open fracture. How are we going to apply this tourniquet? The big thing is to tighten the Velcro as tight as possible first. You should really be able to stop the bleeding just with the Velcro. Once we have the Velcro as tight as possible, we're going to spin the windlass until bleeding stops. That should only be 1 to 2 times, and you should have to struggle to get it that second time. Okay, if you're spinning it 3 or 4 times, it means your Velcro is not tight enough. We're going to secure the windlass into that windlass clip, and then we're going to bring this strap over and secure any extra strap there. Big thing, make sure we're writing the time that the tourniquet went on. Write it on the tourniquet, write it on their forehead, write it on the back of their hand, write it on their chest. It needs to be noted somewhere because that's the first question that these trauma surgeons are going to ask. So if one tourniquet doesn't do the job, we should apply a second tourniquet. The question is, if 2 tourniquets are required, does the distance between the 2 make a difference? Okay, the answer is no. Okay, you want minimal inter-tourniquet distance. If you can get that second tourniquet proximal to the first tourniquet, you want to do that. If not, put it immediately distal to the first tourniquet. What about improvised tourniquets? Are they effective compared to commercial tourniquets? Answer is they are not. Okay, that doesn't mean if we don't have a commercial tourniquet that we don't use an improvised tourniquet, but if you have the choice between improvised tourniquet and commercial tourniquet, we want to make sure that we're using the commercial tourniquet first. If you don't have commercial tourniquet, you need to improvise because you need to do what you have to do to get the bleeding stopped. So when we bridge the gap with regards to tourniquets, mistakes, not using one when we should, not making it tight enough. Again, a tourniquet should eliminate that distal pulse. Not using a second tourniquet if we need one, waiting too long to put on a tourniquet, and loosening or peaking with that tourniquet. We need to make sure that we're reassessing. We just don't put a tourniquet on and leave and never reassess. We need to reassess any time that we're moving that patient and during the reevaluation of that casualty or other interventions. So tourniquets, they do work around the neck, around somebody's neck. They will stop the bleeding, but that's probably not what we want to do. As much as we can think of coaches or athletes that we'd love to put a tourniquet around their neck, okay, that's not the ideal. So we talked about tourniquets. Getting into other devices, we're going to talk about hemostatic dressings and wound packing. Okay, again, we're going to tourniquet the limbs. We're going to pack the junctions. The junctions being your axilla, your armpit, your neck, and your groin area. Okay, when we have wounds in this area, this is where we need to use our direct pressure. If possible, this is where we need to pack the wound, utilize pressure dressings, and utilize hemostatic agents if we have those. Okay, so when we go into wound packing, first thing we want to do is expose the wound. Okay, if possible, we need to remove any excess pooled blood from that wound, but we need to preserve any clots that are already formed. Next, we need to find the bleeder. Okay, we need to look in that wound. Where are they bleeding from? If they're bleeding from artery, you're probably going to see it spurting out. If you're bleeding from a vein, they're just going to be seeping out. Once we find that vessel that they're bleeding from, we want to apply focused direct pressure right on that vessel. Okay, again, if we've done our job, we should be able to go to the hospital if our 2 fingers or 1 finger or a thumb stuck inside that wound and we've stopped the bleeding. Okay, but we can't do that. That's not going to be practical to do that. So we want to find the bleeder, apply that focused direct pressure. Depending on the size of the wound, it may only be 1 finger, it may be your thumb, it may be 2 fingers, it may be 3 fingers, but we want it right on that vessel. We then want to pack the wound. We want to take our gauze or hemostatic agent, or if you're improvising a t-shirt or paper towels, whatever you have, we want to pack that wound, okay? We don't want to release pressure on the vessel, so you can either use a side-by-side technique or you can swap fingers in and out. But we want to make sure we're packing all the voids. We want to pack down to the bone. And once we have it packed, we want to apply at least 3 minutes of direct pressure to the wound and then add a pressure dressing. Okay, so we want to add some more with regards to gauze until that wound is completely packed. You can see here a great representation of what it looks like of packing that wound all the way down to the bone. You can see how that wound is filling up with gauze versus laying gauze over top. you can see how the blood pools underneath there. Again, once we have that wound packed with as much gauze or material as we can stuff in there, we want to hold direct pressure for 3 to 5 minutes, and then add your emergency trauma dressing, your pressure dressing, your ACE wrap, your TheraBand, whatever you're using for that pressure dressing. With regards to hemostatic agents, several different agents on the market. Quick Clot Combat Gauze is the one that's recommended. You can see here the current recommendations from the American College of Surgeons and the Co-TCCC guidelines, which are used by Tactical Medicine. Okay, they're recommending the use of topical hemostatic agents, and TCCC recommends the use of Quick Clot Combat Gauze as its first line agent. There are other things available, but Quick Clot Combat Gauze is shown to work the best, and that's what all the military and most of the tactical units use. So here's a great representation of wound packing. You can see arterial bleed. He's trying to find the bleeder. Okay, he tries to get his hand down there. Now he's opening. You can see with the different motion of opening the gauze that he's loosened up some pressure. Okay, that's a big enough wound. He possibly could have put 2 fingers or 3 fingers in there to get a little bit more pressure. Now he's going to pack the wound. Okay, he's using more of the side-by-side technique. Always trying to keep as much pressure on that wound as possible as you continue to pack the gauze. Okay, here's another representation of wound packing. Just pay attention to how much the person is squirming. Okay. You can see there, now he's trying to find it. Okay. This is where you use your body weight. You could have put another knee on top of there on his leg to keep him from squirming. And you can see he does that right then and there as he's packing the wound. So bridging the gap with regards to hemorrhage control, again, not using a tourniquet or waiting too long to use a tourniquet. Okay, doing nothing when tourniquet or wound packing supplies are not available. Again, making sure you're improvising, packing a wound, or using a tourniquet and assuming that you're done. Okay, those are some pitfalls to avoid. So we've talked about massive hemorrhage. Let's talk a little bit about airway. Okay, after we stop the bleed, we need to check their airway. Okay, we need to check their level of consciousness, do our pulse check, look, listen, and feel. Clear any obstructions in their mouth, but not do a blind finger sweep. If we see something, go in and get it. And then we need to open the airway, head tilt, chin lift, or jaw thrust. If they're not breathing, we need to readjust from there. Okay, if they're breathing, consider the use of a nasopharyngeal airway. If they're not breathing and you're able to, consider the use of advanced airway. If they don't have a pulse, depending on the situation, if this is a mass casualty situation, you may not have the resources and or time to do CPR. We have to utilize our triage rules, consider that person a black triage, and move on to the next person. Okay, so we don't want to be initiating skills that take too long to perform when we don't have the resources. Once we get the resources, we can then go back and do that. So we've talked about, in the devices category, we've talked about tourniquets, we talked about the hemostatic dressings, packing the junctions. Now let's talk about sealing the box, or the utilization of chest seals. So that brings us to R, respirations. With regards to the March protocol. Again, we want to make sure that we're fully exposing the patient. We want to be able to monitor pulse ox if we have the opportunity to. And we want to ventilate for the patient. If they aren't breathing, we want to try to breathe for them. Okay? If they have chest wounds, if they have sucking chest wounds, we want to make sure we're sealing those chest wounds, sealing the box. We're reassessing our breathing after the interventions, using a bag valve mask, using oxygen if we have it. So looking at some present research that's come out regarding the wounding patterns during an active shooter event. Okay, and Stop the Bleed has come out, and Stop the Bleed is great, but is it enough? Okay, to what we're dealing with in this country, which is more of active shooter events than roadside bombs. So this came out in 2016, looked at 12 separate events, looked at the fatalities from them. You can see 58% had gunshot wounds to the head or chest, only 20 had extremity wounds. You can see the probable site of fatal wounding was the head or chest in 77% of the cases. And the most common site of potentially survivable injury was the chest. You can look back at the Las Vegas shooting. 58 fatalities, 22 were to the head or neck, 34 fatal wounds to the chest. Only one person died due to uncontrolled bleeding to an extremity. So that brings us to a sucking chest wound. How are we going to manage it? And the need to not just go through wound packing and tourniquets, but also consider chest seals. Okay, sucking chest wounds when air is pulled into that thoracic cavity through the chest wall instead of through the airways. Okay, understand that a sucking chest wound will turn into a tension pneumothorax if not treated, and if treated, if not monitored. So with regards to the recommendations and research, ILCOR in 2015 came out with, they recommend against the use of occlusive chest seals. Okay, ILCOR, these guidelines were due to be updated this year, but because of COVID, I don't know exactly if they will get updated this year. But understand ILCOR guidelines are talking about the bystander. They're talking about bystander intervention in the untrained lay person. TCCC, which is your tactical casualty combat care, August 2017 came out with a recommendation that sucking chest wounds and all open chest wounds should be treated with chest seals. When we're talking about chest seals, they have commercial devices, they have improvised devices. Unlike tourniquets, improvised chest seals seem to work pretty well. What can we use to improvise a chest seal? You can use just your regular glove. You can use packaging. This is the packaging from the Israeli bandage, packaging from Combat Gauze. The easiest thing that you always have, AED pads. Okay, you can either use the packaging off the AED pads or use the AED pad yourself. So one thing I do is I work with our AED person on campus, and he brings me expired AED pads every month. And I'll cut the wires off, I put a big E on it or a big X on them, and I put them in my kits as chest seals. Okay? Again, those are great to use. They are not vented. Like you can see the commercial vented chest seals here, so you do have to make your own vent. Whether or not you just fold or tuck one of the wires under to make a vent. When we're using a chest seal, wipe off the blood as best as possible. If you're using improvised chest seals, should extend at least 2 inches past the wound. We want to try to apply the chest seal during expiration rather than inspiration if possible. Again, we're supporting ventilations, we're breathing for the patient if possible, and we're going to monitor for respiratory distress.
Use the red tabs as an indicator of where to tear. Once removed from its pouch, wipe any dirt or fluid from the skin with the gauze. Grip the red tab to peel the clear liner from the dressing. Now center the vent over the wound. Firmly press onto the skin for a good seal. It is very important to make sure you smooth out all edges flat against the skin. Assess the patient carefully on the front and back of the torso and under the armpit areas. Assure the patient that help is on the way.
So again, you probably aren't going to have time to nicely get all the wrinkles out and smooth it. But the key there is reassess the patient, roll them over, because generally if they've been shot in the chest, it's exited somewhere on their back or underneath the armpits. And then continue to reassess this patient for breathing difficulties. With regards to a pneumothorax, the thing we're concerned most about is our tension pneumothorax. Okay. This is where that injured lung acts as a one-way valve and traps more air. And you can see here in this picture here, the air is coming in here, okay, and it's pressing up against that lung. You're getting a little shift here of the mediastinum, pushing the heart, and now it's affecting that left lung as well. So what are our signs and symptoms? Shortness of breath, difficulty breathing are going to be the number one sign and symptom. They're going to have decreased breath sounds on the affected side. They're probably going to have chest pain. They're going to have tachycardia. They're going to be going into respiratory distress or arrest. What are we going to do with that person? We need to burp that chest seal. We need to either remove it temporarily or we need to burp it to allow some of that air to escape under there, and then continue to monitor that patient. That is why the vented chest seals is what recommended, because they're vented and it automatically allows that air to escape. But if you aren't using a vented chest seal, you're using an improvised chest seal. You can tape all four sides, leave one corner open. That will allow some level of a vent, or you just need to burp it, or just totally temporarily remove it if you do have signs, symptoms of a tension pneumothorax. So moving on to C, circulation in the march, okay? Our goal here is to prevent shock, okay? We've taken care of the bleeding, we've taken care of the airway, we've taken care of respiration, we've breathed for the patient, we've monitored any kind of sucking chest wound, we've treated the tension pneumothorax. Now we're on to optimizing their circulation or preventing shock, okay? We're going to do that, lie them flat, make sure we maintain their body temperature, put blankets on them, keep them warm. If we have the ability for fluid resuscitation, we're going to do that. We're going to maintain our ABCs. But the big thing we're going to do is we're going to do our secondary sweep, okay? DCAP, BTLS plus C. We're going to start head-to-toe exam, head-to-toe secondary exam, looking for deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, swelling, and crepitus, okay? We're going to go from head to toe looking for all this. This should not be your 30-minute knee eval. This should be a quick 30-second, 45-second secondary trauma eval or rapid trauma assessment. So what happens when you start to bleed? It obviously depends on how much blood you've lost and where you're bleeding from. You can see here in a pelvic fracture, you can lose up to 5 liters of blood. 1862, definition of shock, Samuel Gross, the rude unhinging on the machinery of life. Okay, we've come away from that definition a little bit, but it still rings pertinent. Now it's more of an inadequate tissue perfusion with oxygenated blood to sustain aerobic metabolism. Understand shock is a progressive condition, okay? It gets worse over time. The effects are initially reversible, but they become rapidly irreversible if we don't recognize this and we don't treat this, okay? The median time from onset of shock to death is 2 hours if not managed. So how quickly shock occurs depends on where and how the damage is. You saw in that chart previously that you can bleed at different rates from different parts of the body. But again, that bleeding out and death can occur in as little as 3 to 5 minutes. Remember that platinum 5 minutes, and new research saying that 3 minutes is considered the gold standard right now. So we're going to be looking for signs and symptoms, okay? Again, we want to be in this green, okay? About 5 to 25% blood loss. They're going to be somewhat symptomatic, but this is where we can stop that bleeding, keep them warm, treat them from shock. Once we get into irreversible shock, when you have that cell death and organ system failure, okay, they're pretty much going to pass away at that point. So how much blood do we have? A normal person has about 5 liters of blood volume in their body. So what happens when we lose about 15% or about a half liter of blood? We're still alert. Our radial pulse may be a little full. Are we going to die from this? No. That's like giving blood at a blood bank. What happens if we lose a liter of blood? Almost 20% of blood loss. Are we going to die? Probably not. That person's still alert. They still have a radial pulse, which means that they still have a blood pressure of at least 90. Their respiratory rate's still going to be normal at that point. A liter and a half of blood, about 30%, this person's probably not going to die if they get immediate treatment. Okay, you can see here the systolic blood pressure may be dropping, radial pulse may be weakening. They're going to be alert but anxious. Their heart rates are going to be very tachycardic. Their respiratory rate is going to be elevated. 2 liters of blood, okay, this may be what's known as a pre-terminal event. Okay, this person, their mental state's going downhill. They're confused. They're lethargic. Capillary refill is delayed. Systolic blood pressure decreased. Radial pulse is even weaker. Then we look at 50% blood loss. This person's probably going to die unless they get to a trauma center right away. This is the unconscious person. If you remember back at the beginning, we talked about what does uncontrolled bleeding. It's the person that's laying down there that's bleeding but is unconscious. Okay, that's a sign of uncontrolled bleeding. So when we get to H stands for hypothermia and head injury. Okay, there's what's known as a trauma triad of death. Okay, it's hypothermia. Okay, we want to keep this person warm. We want to minimize their exposure. It's hypoxia. Okay, we want to make sure that we keep this person breathing, that they have enough oxygen running through their body, that they don't go into acidosis. And then it's hypovolemia or hypocoagulability. Okay, we want to make sure they have the blood volume and that blood doesn't start to thin. And once it starts to thin, it has a reduced ability to clot. Okay, that's not good. So we want to avoid these H bombs or the trauma triad of death. Again, when we get the head injury, this is part of our DCAT BTLS. When we start at that head, we're looking at the eyes. Are they equal, reactive to life? Do they have raccoon eyes? Do they have battle sign? Do they have cerebral spinal fluid? Looking in the mouth, are there any lacerations, obstructions, broken bones, blood, or swelling in the mouth? And again, avoiding those H bombs. Okay, avoiding that hypoxia. Okay, we want to keep their pulse ox above 90. So if we can get them oxygen, we can breathe for them, but we don't want to hyperventilate for them. We want to make sure we're breathing at a good 1 breath every 5 to 6 seconds, no more than 12 breaths in a minute. We want to keep their blood pressure up, which involves stopping the bleeding, keeping the blood volume up, and we don't want them to go into hypoglycemia. And E stands for eye injury. Okay, it stands for eye and everything else. Okay, we want to tend to any eye injuries. If it's a chemical burn, we want to flush it out with water. And then everything else, again, we continue to monitor them. We continue to do our secondary trauma assessment. We continue to reassess at various intervals. If we have the ability, you can do what's known as pause, pain management, antibiotics, wound reassessment, and splinting. That's more in a tactical environment. Okay, but they will most likely take care of that when paramedics come or when they get to the ER. But again, we want to make sure we're continuing to do our head-to-toe secondary exam. We want to evacuate them from the scene as safely as possible and as soon as possible, and we want to document this. So the thing we don't need to forget about is our critical incident stress management. Okay, athletic trainers are notoriously great at this. In terms of making sure our student athletes are taken care of, making sure our coaches, staff, and administration are taken care of, making sure our friends and family are taken care of, but we aren't great at it. We aren't great at putting on our oxygen mask before helping others, okay? We need to take care of ourselves as an athletic training profession. AT Cares is an incredible organization. It's an incredible organization that's built for, and its main purpose is athletic trainer to athletic trainer, peer-to-peer support. Please, 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 when you're in these situations or you're having difficulty, make sure you reach out to AT Cares in addition to your campus and community resources. But AT Cares is there to help athletic trainers. So bridging the gap, what do you need? Okay, you need something you have access to. It does no good if your entire kit is under the bus and you don't have access to anything right away. You need something that you're comfortable using. You need something that you can use in a hurry and something that you can get, create, and or replace. Okay, if you're going to make up a go bag, what does that go bag entail? Entails tourniquets, entails pressure dressings. Again, that can just be an ACE wrap. You can have just rolls of TheraBand. Those can count as a tourniquet and or a pressure dressing. You need some level of gauze or wound packing, hemostatic agent, something to make a chest seal out of. Again, that can be just an expired AED pad that you were going to throw away. Doesn't mean you got to go out and buy or pay for a $200 go bag. There are things that you already have in your athletic training room, obviously glove, and then any supplies that you would need to carry out the March algorithm. Okay. Again, understand your preparation is your success. And if it's predictable, it's manageable. We should be able to manage anything that we can predict is going to happen. So in summary, the more you prepare beforehand, the more relaxed, creative, and effective you'll be when it counts. And so ask yourself, are you prepared for the ultimate emergency? Okay. Are you prepared when these things that we normally don't associate with athletic training, but are going to happen at some of our events? Are you prepared for that ultimate emergency? Again, thank you for your attention today. I'm happy to entertain any questions that you may have. You can always reach me at the DCATC at umiss.edu email address, or the Sports Medicine Emergency Management, SMEMATC@gmail.com. I appreciate your attention. Please do not hesitate to reach out and ask any questions that you have, and I'll make sure that I respond either by email or text message. And again, if it's predictable, it's manageable. This is something that can and will happen in your lifetime, that you'll have to manage some level of an emergency like this. And just make sure that you're prepared, make sure that you practice, make sure it's something that you can do and you feel comfortable doing. And don't forget about calm is contagious. We need to stay calm at the time of emergency. Thank you.